Season 1 of Medsplaining is brought to you by Estee Lauder. With 40 years of night repair expertise and 30 years of collagen research, Estee Lauder are the experts in nighttime skincare. Before we get into today's topic, make sure to subscribe to the Medsplaining podcast on your favorite podcast platform to never miss an episode. I want to tell you about my nighttime routine, which includes two incredible products: Estee Lauder's Advanced Night Repair Serum and new Overnight Treatment work together to transform your skin. This power pair minimizes key signs of aging and helps your skin recover, feel softer and smoother. With these two products, Dream Skin is just one sleep away. Welcome to Medsplaining. I'm Dr. Jennifer Zelevitsky, your host. I'm a medical doctor and a women's health expert, and today we have a special mini episode for you of listener Q&A. I'm going to answer some of the questions that have come in and hopefully shed some light on some of your most pressing concerns. And to do this, I've brought my pal Marnie. She has Marnie. What's that you have?
This is my box of questions.
Oh, so why don't we get started? Let's pick the first question.
All right. The first question says, I have a history of uterine cancer and have been told I can't use hormone therapy, but I am struggling with hot flashes. Do you have any suggestions for me?
Oh, this is a great question. Surprisingly, although people often think about breast cancer being the reason you can't have hormone therapy, actually uterine cancer is one of the very few contraindications for hormone therapy, meaning like a reason why it wouldn't necessarily be safe to use it. This is because uterine cancer, which affects the lining of the uterus, is stimulated by estrogen in most cases. I have to say, it depends on the type and the grade, or in other words, how aggressive the cancer is, that will determine whether you may still be a candidate. And of course, if you've had a hysterectomy and it's low grade and it's a reasonably well-controlled cancer by surgery, maybe you're a candidate. But this is really one of those situations where you want to talk to an oncologist, a menopause expert who's well-versed in this.
Right.
The good news is you do not have to suffer just because you might not be a candidate for HRT. There are really good ways to manage, for example, hot flashes and mood disruptions and sleep disruptions, even without hormone therapy. One example is an SSRI or an SNRI, which are traditional antidepressant medications, but they are reasonably effective at both managing hot flashes and mood.
I didn't know that.
And another option, especially if you're having night sweats and poor sleep, gabapentin.
Wow, I have heard that.
It's a nerve pain medication, and it can be very, very helpful. I've used this very successfully in uterine cancer survivors in terms of helping with sleep and managing those nighttime hot flashes. So you can certainly get help. Don't just settle for suffering.
Don't suffer.
Don't suffer. There are options, even if HRT isn't one of them.
Moving on to our next question is, I am 70 and have never been on hormone therapy, but I am really struggling with frequent bladder infections and vaginal irritation. What can I do?
This is a great one. I am so happy that they are working hard to remove the black box warnings and the FDA labels from vaginal estrogen, at least in the US, because vaginal estrogen is a safe, effective treatment for vaginal dryness, pain with intercourse, urinary or vaginal atrophy, and frequent bladder infections in older women. And the great thing is, it is never too late to start. And there is almost nobody that wouldn't be a good candidate or a safe candidate for it. So to give you a sense of the dosing, you would have to use vaginal estrogen for an entire calendar year to equal the amount of estrogen in one birth control pill.
Wow.
It's extremely safe. It stays locally in the vagina. They have done long-term studies proving the safety of vaginal estrogen. This is something that you can start no matter how far out you are from menopause, and it's very, very effective. And if one particular type doesn't work for you, there's other types. There are creams, there are tablets, there are newer suppositories. Most family doctors, even if they're, not comfortable with HRT, will be comfortable prescribing a vaginal estrogen.
Right. And I feel like a lot of women of that age, like the 60 plus 70s, grew up when the doctors weren't so pro menopause, perimenopause. And so then they're reluctant to go on these kind of.
Or they were on it and they were taken off of it.
Yes, taken off of it.
The Women's Health Initiative, right? Because they were in their 50s 20 years ago. I recently attended a talk, and this fabulous urologist was telling us how vaginal estrogen is a prebiotic for the vagina, and it actually helps the vagina reset its pH balance, which in turn helps minimize infections,
right,
including urinary tract infections. I mean, UTIs are a major cause of mortality, especially in nursing homes. Yeah.
In nursing homes. Yes.
And in older people.
Yes.
And they can
it affects them cognitively.
Exactly.
Yes.
They can fall. They can hurt themselves. It's a serious thing. And it can be so easily prevented or at least minimized by vaginal estrogen.
Okay. Here's a good one. Does hormone therapy help with weight loss?
I get asked this question every day. So the answer is yes and no.
Okay.
Before we get it's really important to understand what drives weight gain in menopause, because in perimenopause, the years actually leading up to it, we start to see significant changes in our body composition. We see a loss of lean muscle mass starting around age 35, but really accelerating in the years leading up to the final period and then continuing for several years after the final period. And that muscle gets replaced by fat.
Right.
But it is not the same subcutaneous healthy fat that we have under our skin that provides insulation. It's visceral fat, which is a different type of fat. It's metabolically active, but not necessarily in a healthy way.
Right.
For some women, at least, it stores more cholesterol, so the cholesterol levels go up. It causes glucose metabolism, so you start to see insulin resistance. It's pro-inflammatory. Inflammatory cells in the body increase, so you get aches and pains, and we see increase in inflammatory disorders in women after menopause. But that visceral fat has one thing going for it, and it can produce a little bit of estrogen.
Oh.
Yes. So after menopause, our fat cells become our main source of estrogen. And they haven't done, of course, like all things, the caveat is, have they done big studies on this in humans? No, but from animal studies, at least, the body is driving itself to create more visceral fat because it's like a hack. It's like, we can get a bit of estrogen here, and our body so desperately needs the estrogen. Might as well get it from somewhere. But the other thing is, lifestyle does play a role.
Right.
People often blame their metabolism. We know that it only slows down by about 200 to 300 calories at menopause, which is like a snack, right?
Right.
But it's not a massive shift in our metabolic rate. But we're not always conscious of the fact that when we're tired, when we're in pain, when everything feels like it's going wrong, we're not moving as much as we once did.
Right.
We're not fighting cravings as much as we once did. We have a sedentary job. We have a lot of obligations. Something's always getting in the way of taking care of ourselves. And sleep is a big part too.
Yes.
There's a study that shows that women who get less than 7 hours of sleep a night gained more weight in menopause than women who got 7 hours. And it's impossible to get 7 hours if you're having hot flashes, night sweats, disrupted sleep, anxiety, palpitations. Right. Okay. So that's what's driving the weight gain. So if I were to give you estrogen and you just sit around and don't change anything about your lifestyle, you will not lose weight.
Right.
And so this is where I break it to my patients gently. But what I tell them is, if you're trying to do all these lifestyle things and you're really struggling with symptoms and they're getting in your way, it's like trying to drive with the parking brake on.
Right.
And so for a lot of women, if they're symptomatic, they start hormone therapy and it's like the parking brake comes off because their estrogen receptors have a source of estrogen, and it doesn't take much. It can be a low dose, but it allows them to sleep better,
right?
To then fight cravings a little bit
and
better.
You have more energy. So
more
you can
energy,
move more, you're more motivated.
A little less achiness,
right.
a little less pain, so they can start to weight train because, again, we're losing muscle mass. You want to be putting muscle mass on. One thing a lot of people don't realize is it's muscle that establishes our basal metabolic rate.
Right.
Whatever amount of muscle you have on your body determines how many calories you can be burning at rest.
Okay.
And so we have to combat that loss of muscle mass first and foremost. And so, yes, of course, you need the protein to build muscle. You need to be sleeping well. You need to be minimizing alcohol. You need to be eating the right nutrition. But hormones can allow you to move the needle, allow you to drive the car, but they're not going to be like the thing that's leading to weight loss. Right. And it certainly isn't going to happen overnight.
Okay, cool. All right. Next question. Can someone start hormone therapy if they're over 60?
Okay, this is a great question. The rule of thumb is that it is best to start in what we call the window of opportunity, which is within 10 years of your final period or during perimenopause, whenever that is, because symptoms start in perimenopause. So actually, there's another thing I want to just say quickly, which is you don't have to wait till a full year without periods to start hormone therapy.
Right.
It's another common myth. So I want to shoot that down right now. So if you're starting during perimenopause or within 10 years of your final period, that's safe. So for example, if you have your final period at 55, you have until 65, until that window kind of closes where the benefit will outweigh the risk. The reason they say or 60 is because some women have a surgical menopause, or they have an IUD, or they have some other thing, or they can't remember when their last period was.
Right.
So then we take the average age of menopause, which is about 50, 51. Globally, it's closer to 48. So let's just call it 50. And that means 60 is still reasonable for starting. So having said that, these are guidelines. They're not rules. They're not individualized. So a lot of women will have symptoms beyond age 60. And so you do not have to stop hormone therapy at all. In fact, that's a whole other discussion, but you can continue it safely if you've been on it in the window of opportunity, carry on. But if you are symptomatic, you're over 60, you deserve to have that discussion with your doctor because it's an individual approach. It's based on the fact that we're sort of assuming that beyond 10 years out from your final period, you've developed some cardiovascular disease, right? You've developed some plaques in your arteries, or you have other health problems, which might make it unsafe to start hormone therapy at that point in time. But I have had symptomatic, perfectly healthy women in their mid or late 60s who had a later menopause that we've safely started on low-dose hormone therapy. But this is a really individual decision. The guidelines are sort of like the general rules.
You would probably have to do like a cardio workup or something.
Yeah. We do a thorough cardiovascular assessment to ensure that they are safe to start. We usually use like the safest options, like topical estrogen, not oral estrogen, to really minimize. And it's a detailed discussion. It may be a low risk. It may be an unknown. There's a lot we don't know. So you want to discuss it with someone who's well-versed in this area of care, who has a lot of experience.
I was just going to say, it just points to the fact it's so important to have a certified menopause practitioner or someone who's very well-versed in it rather than, just your family doctor who might not have all that info.
I was the worst as a family doctor. I was the same. I was saying all the things I'd learned, which was, it's dangerous. Don't do it. It causes breast cancer. Wrong, but that's what they're still being taught. So it's not their fault. It's miseducation.
I feel like the Gen Xers, like our age, are really not Gen Z, but Gen Xers are really getting the topic of menopause and perimenopause and hormones out there because we're all going through it. And like, it's not like we're not like our mothers who are sitting quietly suffering. We're really getting it out there to talk about it. And it's super important. And it's important for our daughters and stuff so that we can help them. So we know and they know from our experience.
Our daughters are part of a shame-free generation.
Yes. Absolutely.
And then I always wonder too, like our moms just were shut down at every turn.
Yeah.
What was the point in going to somebody about your symptoms?
Right.
You were offered a sweater to wear to layer yourself up and said that you're at that age now. Haha, congratulations, and making jokes about it. They didn't have an opportunity to get help. So I think they learned to be shut down. And then they didn't talk to us about it.
No.
So we talked to each other about it.
Right. And now we'll talk to our children about it.
My daughters know way too much about menopause.
Oh, I'm sure.
My dogs know way too much about menopause at this point.
Your dogs. That's funny. Okay, moving on. My skin is really dry and thin. Should I consider hormone therapy to help this?
This is a tough one. The short answer is if that is your only concern, that's your only symptom, no.
Consider yourself lucky.
Here's the deal. We know that skin, hair follicles, nails, like our cells have estrogen receptors. We do see a loss of collagen and other issues in our skin and our nails and our hair with the loss of estrogen, like everywhere else in our body. The problem is it's very unpredictable whether the estrogen from hormone therapy will reach those receptors.
Okay.
So I do have some patients who just tell me they're taking hormones for other reasons and they notice it's improved their skin. It's reduced maybe the redness in their skin, the rosaceous flaring, and maybe it's not flaring as much. Or they are noticing their hair isn't shedding as much. But that might also be because they're sleeping better.
Right.
They're feeling less stressed and anxious. We can't really point to the estrogen as what's solving that problem directly.
Okay.
But the good news is there are fantastic dermatological approaches. So I'll often refer my patients to a dermatologist, such as my friend, Dr. Jen Tran, who has fantastic advice about managing your hair, your skin, your nail changes during transitional times in your reproductive life, like pregnancy or postpartum or perimenopause. So it's often a multifactorial approach, like many things in menopause care. So that would not be a good reason. I certainly wouldn't use hormones exclusively for skin or hair concerns.
Right. A lot of women complain about acne.
That's because it's thought to be because when estrogen is dropping, it's doing so earlier and faster than, say, testosterone is. So that androgens like testosterone and androstenedione, like these male-associated hormones that we have too as women, they don't drop as early or as fast. So it creates a relative imbalance. And when you have too much of those male hormones floating around, that's what causes acne. So that's one of the reasons we see
men cause acne. Got it. Okay, next question. I have a progesterone IUD. How can I tell if I'm in menopause?
Okay, so the progesterone IUD is like a Mirena or a Kyleena. This is the type of IUD goes in your uterus and it gives off a little bit of hormone called a progestogen or a synthetic progesterone every day. It keeps the lining of the uterus very thin and stable and prevents pregnancy. And a lot of women have them in perimenopause to manage heavy bleeding or for contraception. The IUD does not affect your hormone levels. It's not like a birth control pill, which does artificially affect your hormone levels. So it's not reliable. But with the IUD, it is reliable. So there's a test called an FSH or a follicle stimulating hormone. This is a hormone that comes from your brain, basically. And it signals your ovaries to produce more estrogen. And then when the ovaries produce more estrogen, the FSH gets the signal back and it keeps it at a relatively low level. So it's lower when you're having ovulatory periods or before menopause, right? Okay. After menopause, it reaches a higher level and it's like it's signaling, come on, estrogen, let's go, and nothing's answering back. So I think of it as like it's yelling because no one's answering, right? Like a mom when her teenagers are
Yes.
ignoring them. So the FSH stays high. So if you go to your doctor and you say, I think I'd like to see if I'm in menopause. I'm no longer having spotting or any bleeding. It's been a long time. Can we check my FSH level? You want to check it twice, 2 months apart. Because if it's elevated twice, 2 months apart, that's a pretty reliable marker that you're in menopause and you can consider removing it and you're unlikely to have any more periods.
So you would remove it and then automatically go on HRT or wait a bit?
So that's a great question. If you've had it for less than 8 years, even if you're menopausal, you don't have to remove it. For example, if you're on HRT, it's a fabulous progesterone component.
Oh, right. Okay.
Right.
Yeah.
So I myself, I have a Mirena.
Right.
And I have topical estrogen. And this is a very common regimen that I put my perimenopausal women on who are symptomatic because you get your progesterone to protect your uterus and you have your estrogen. Now, if I were to remove my Mirena, I would have to go on to another form of progesterone.
Right.
Because you never, ever want to take estrogen without progesterone.
Right.
Or you will eventually get uterine cancer. So that has to be very clear. But suppose tomorrow I'm in menopause. I don't have to remove my Mirena. I can keep it for the full 8 years as my progesterone component. There's nothing pressing about removing it until it's reached 8 years.
Okay. I have a question. When do you need to add or do you need to add testosterone?
Ooh, that's a great one. Need? No. No. Testosterone right now is having this wave of momentum on social media. Yes. It's a misleading wave. Okay. So testosterone, as I said before, it is produced by our ovaries. It does not drop as early or as abruptly as estrogen and progesterone. And in women, almost all of our testosterone gets converted to estrogen. Testosterone can be useful and is indicated in Canada for one main purpose, which is what we call like hypoactive sexual desire disorder. And what that means, at least to me and through my experience with women, is you solved kind of the vaginal dryness and discomfort. So sex is comfortable, sex is enjoyable, you're well rested, it's back on the menu, but you're still but you're still not able to get there. Like you just can't be motivated at all.
Okay, your libido is still low.
Yeah, and it's tricky because when we're not ovulating anymore, it's not realistic to expect yourself to be having that biological drive to procreate.
Right.
So like whether you have children or not, it's not about that. Biologically, we're mammals, right? And so ovulation sets off this drive to procreate,
right?
Whether we're aware of it or not. It's not realistic to expect that to happen, right? So what I always tell my patients is the order of operations is going to change at menopause, and that is acceptable. That is fine. There is nothing to say that's not okay except society. Men produce sperm until the day they die.
Right, of course they do.
So they don't lose that biological drive to procreate.
Right.
It's a cruel joke of nature. So the good news is estrogen usually does the trick for most women because it can help you with vaginal dryness, vaginal discomfort. Maybe you're having UTIs all the time. Maybe you're bleeding all the time. So we need to get you on the right regimen to take care of the bleeding. It can help you sleep better, feel less irritable, so that you're willing and able to engage. But then what you have to understand is it's actually okay if arousal kicks in the moment.
Right.
Instead of before. So it's initiation that a lot of women are talking about. Mm-hmm. Initiation becomes more of like a cognitive exercise than a physical one. I don't know that I would prescribe testosterone to someone based on that. But if it's like the thought of even having sex, just feel like I recoil inside, or I cannot have an orgasm, or I cannot enjoy it no matter what I've tried, then testosterone might be a good idea. It has to be monitored to stay within female range, because if it goes above female range, you can get permanent voice changes.
Oh.
You can get more acne, hair growth in places you don't want it, and something called clitoromegaly. And some of these changes are not reversible, right? And this is why.
Wow.
Yeah. And they're seeing it in the women that are getting the high-dose testosterone pellets and off-label, unmonitored, unregulated testosterone. There's some emerging evidence that testosterone might do things for our mood, for our muscle tone and stuff. But it's too soon to say, wow, yes, it does all these things and everyone needs to be on testosterone. So this is a daily conversation that I have with people because, again, it's the Dr. Google versus reality situation. I know that was a long-winded answer, but I think it's important because it's hard to separate out what's real and what's not. People feel left out if they're not on testosterone.
Right.
You're not left out. Estrogen is still the heavy hitter here. It's still the main character, and it's the thing we need the most.
Okay, next question. How long can I stay on hormone therapy?
I love this question. So we used to say, and even I was saying a few years ago, 5 years, and then we talk about discontinuing it. This is no longer the standard of care.
Thank
Marnie's
goodness.
eyes just...
Yes, I'm like, 5 years.
As we're picking apart the data, for lack of a better word, from the Women's Health Initiative. So the Women's Health Initiative, without telling the whole story, but the came out of the Women's Health Initiative was when older women were put on hormone therapy, they had higher risk than younger women.
So what do you mean by it's a higher risk?
The older women had a higher risk of a heart attack, stroke, blood clot. They also had a higher risk of dementia and possibly breast cancer, although that's largely been debated, let's just say. So they sort of extrapolated from that must mean if you're on it when you're older, you're higher risk. And so we should probably get you off it when you're older.
Right.
Now they know. We have a lot of good data to support the fact that if you started in that window of opportunity that we talked about before, you can safely continue it for as long as you and your doctor decide that it is a good idea for you. You should consider lowering the dose maybe. Once you're several years out from menopause, you may not need as high a dose. You will reap the benefits in terms of your bone density, heart health, possibly cognitive health. I'm always being cautious because we need more data.
Right.
But what we know so far is all pointing in that direction of continuing it lifelong. But if you do make the decision to come off of it, which is also reasonable, and you don't have symptoms anymore, you do want to continue to think about minimizing your risk of osteoporosis, right? So you'd want to talk to your doctor about getting an updated bone density test, considering another option for bone density. Make sure you're optimizing your calcium, your vitamin D, and think about your heart health. It's, again, lifestyle is still the crucial piece here.
Right.
But you do want to start thinking about it more carefully if you come off your HRT because you're losing that protective element. And, you know, the Women's Health Initiative, there's, again, a lot of people out there saying it's a bad study. It is not a bad study. The data is excellent. I'm so glad we have it because it's now what we draw on to prove how safe hormone therapy is.
Right.
Well, this was a fantastic episode. We'll have
Very
to do this.
informative.
We'll have to do this again. Send us your questions. DM us. Follow us. And don't forget to subscribe on YouTube, Instagram, LinkedIn, Facebook, and any podcasting platform, wherever you get your podcasts. We love your questions. Keep them coming. Marnie, thank you as always.
Thank you. I love being here.
It's great to see you. We'll be seeing you again, I'm sure. And thanks for watching Medsplaining. We'll see you next time. Thanks for listening. Don't forget to follow us on Instagram, Facebook, LinkedIn, and TikTok at Medsplaining. If you have any questions, shoot me a DM. And if you like this episode, the best thing you can do is tell a friend or rate and review it wherever you listen to your podcast so other women can discover it. And don't forget, if you're listening to this, you may be happy to know that we video every single episode, so you can watch it if you prefer on YouTube. See you next week. Medsplaining is produced by Ghost Bureau. Thank you for tuning in to Medsplaining. While we strive to provide accurate and insightful information, this podcast is not a substitute for professional medical advice, diagnosis, or treatment. The opinions expressed by our host and guests are their own and should not be interpreted as medical advice. Every individual's health situation is unique, and it is crucial to consult with a qualified healthcare provider regarding your specific concerns and conditions. Additionally, any links, resources, or references mentioned in our episodes are provided for informational purposes only and are not sponsored by Medsplaining. The producers and hosts of Medsplaining assume no responsibility or liability for any actions taken as a result of listening to our podcast. We encourage you to use the information presented here as a starting point for discussions with your healthcare provider. Information and references are subject to change based on scientific evidence as it evolves over time. The hosts and producers of Medsplaining are not responsible for future changes to the information and references and assume no obligation to update based on future developments. Remember, your health and well-being are paramount. Thank you for listening, and we look forward to exploring more topics in women's health with you in future episodes.